clinic with Ball State Community College Respiratory Care Program, and today I'll be doing a clinical simulation walkthrough of weaning a COPD patient off of the ventilator and starting them on a BiPAP. Mrs. Tubbs, a 50-kilogram ideal body weight, emphysematic patient who has been living with the diagnosis of COPD for almost 35 years, is currently being mechanically ventilated. Dr. Chrisman has asked me to be very cautious with the weaning and liberation from mechanical ventilation due to previous reintubations after extubations with this patient. She has been mechanically ventilated 3 times prior to this hospital stay for COPD exacerbation, and each time she has had difficulty maintaining spontaneous ventilation post-extubation. After checking the chart and seeing her history, I decided to check for the normal baseline ABG for this patient. Her baseline ABG values on a 2-liter nasal cannula are as follows: a pH of 7.38, a PaCO2 of 60, a bicarb of 30, and a PaO2 of 60. These values reflect her diagnosis of COPD and demonstrate that she is a chronic CO2 retainer. I observed current chest x-ray findings and note that she has a flattened diaphragm. A flattened diaphragm results in decreased respiratory muscle strength. This loss in the respiratory muscle strength must be taken into consideration when weaning because it can result in the loss of ability to efficiently take spontaneous breaths. We need to make sure her secretions are cleared because of the inability to effectively clear secretions, and this occurs due to the decreased muscle strength. When weaning a COPD patient, it is invaluable to wean the patient to their appropriate baseline ABG. If weaned to a normal person's ABG, the COPD patient will ultimately fail in the weaning parameters. Upon entering Mrs. Tubbs' room, she is resting comfortably, and I observe her current ventilator settings that are as follows. We have Ms. Tubbs in SIMV volume control. Her set rate is 10 with a set tidal volume of 450. She is breathing 13 times a minute, which we obviously can't see on this vent because we have a test lung, and her spontaneous tidal volume is 250 milliliters. We have her in pressure support of 5 and a PEEP of 5, and her FiO2 is at 35%. Her vitals are stable and they reflect a normal COPD cardiopulmonary disease. Her SpO2 is 91, and Dr. Chrisman asked she be weaned to minimal mechanical values of SIMV rate of 4 due to her long-standing COPD. I decided to turn down her rate in increments of 2 and allow her 2 hours to adjust to having to take more spontaneous breaths before I make another rate change. After the rate change, I will titrate the FiO2 down to 33%. I decided to wean the FiO2 in small increments due to her sensitivity to oxygen changes. I will maintain her pressure support at 5 and her PEEP at 5. This will allow her to overcome the resistance of the ET tube and take optimal breaths. By keeping the PEEP at 5, this will allow her alveoli to be stented open, and due to her predisposition of premature airway closure. 30 minutes after each rate change, I will draw an ABG from her ART line to better assess her ventilation and oxygenation. I will correlate the ABG values with her SpO2 and EtCO2. This will assure that our non-invasive measurements correlate with our invasive measurements. Several hours later, she has the following ventilatory settings. She's in the mode of SIMV, rate of 4, total rate of 12, so she's taking her own spontaneous breath, mechanical tidal volume of 450, and her spontaneous tidal volume of 400. I still have the pressure support at 5 and the PEEP at 5. Her FiO2 now is at 28%, same as a 2-liter nasal cannula. Throughout the weaning process, I have closely monitored her vitals, ABG values, and meticulously patient assessment for any signs of respiratory distress. On the previous ventilatory settings, her ABG values are as follows: a pH of 7.38, a PaCO2 of 60, a bicarb of 30, and a PaO2 of 60. Since her ABG and patient assessment was stable, I contacted Dr. Chrisman with all of her settings and values, and she ordered a spontaneous breathing trial. She wants a pressure support at 5 and PEEP at 5 and to maintain the current FiO2 setting of 28%. And on this ventilator, to put her in pressure support, which it won't work because we have a test lung, I would go down to spontaneous and hit continue and accept that we have pressure support at 5 and her PEEP at 5 and change her FiO2 down to 28% and accept. Of course, with this lung, it's not going to have any spontaneous respirations, and we'll kick into our SIMV backup mode. 30 minutes after initiating the spontaneous breathing trial, I obtain an ABG and weaning parameters. Her ABG values are as follows. Her pH is 7.36, her PaCO2 is 62, her bicarb is 30, and her PaO2 is 58. Her spontaneous tidal volume is 375, and her respiratory rate is 14. Her Tobin index is 35, which is great, and her vital capacity is 750. Her NIF is a negative 27, and her SpO2 is 92%. Her end-tidal CO2 is also 48. Ms. Tubbs is extubated to a nasal cannula at 2 liters per minute, which she usually wears at home, but almost immediately becomes tachypnic with an SpO2 of 86%. She appears to be hyperventilating. I would expect her PaCO2 to be lower than her normal range and her PaO2 to be lower than normal. As she weakens, she'll begin to fail, and her PaCO2 will begin to rise above her normal level. After sharing these findings with Dr. Chrisman, we decided she needs immediate BiPAP therapy to assist her spontaneous breathing efforts. I decided to use a full-face mask because she is an obligate mouth breather and she is in distress. I would fit her using this plastic guide, and since she is a smaller lady, I would start with this smaller opening, and you want this to be on the bridge of the nose and this to be below the chin. And you would do it like obviously I would need a medium. After fitting her with that, she would need a medium. I want the top of the mask, like I said, on the bridge of the nose, and the bottom to be right on the chin. I set the following parameters. She's going to wear an IPAP of 10, an EPAP of 5, an FiO2 of 35%, and a backup rate of 12. And I'm going to turn this on. And on this mannequin, I have placed a BiPAP mask, bridge of the nose, bottom of the chin, and it is snug on there but not too tight. And here, this is going to alarm because the patient isn't taking spontaneous breath. We have IPAP at 10, EPAP at 5, backup rate of 12. We had to set our FiO2 on 21% because we don't have oxygen here in the lab. But this is how you would have set it on Ms. Tubbs. I'm going to put this off. After I place the mask, I observe her spontaneous tidal volume to assess the delta P is sufficient. And this means that she's going to be getting the required tidal volume she needs for her size. Her spontaneous tidal volume is 400 milliliters. I will monitor the effectiveness of the BiPAP therapy by using patient assessment, especially her level of consciousness, vitals, and ABG values. If she is to begin to decline in responsiveness, her vitals were unstable, we would call a rapid response and possibly prepare for reintubation for Ms. Tubbs.